My name is Ch.R.Worz. I am a pharmacist from America. I have been a pharmacist for 25 years. I started in a small community pharmacy as a 14-year-old stocking shelves and worked in pharmacy ever since. My first professional job out of pharmacy school was in long-term care. And I've worked in long-term care in various capacities for over 25 years, most recently with ASCP as chief executive for the last 6 years. And my job this morning is to kind of give you a sense of the American system of long-term care, particularly from the perspective of the pharmacist. So if we look at older adults globally, we know that there are a growing population of older adults. That's not new to anybody in the room. By 2030, there will be nearly 1 billion adults over the age of 65 around the globe. By 2050, more than 1.5 billion. In first world countries, this boom includes a massive explosion of individuals also over the age of 80. The number of Americans 65 and older is increasing in the US from 58 million people to 82 million people by 2050. That's a 47% increase. So the curve is steep in the US for people turning 65, people turning 80 years old. The share of individuals in our population is going to grow from about 17% today to 23% over the next decade. We have an older nation. We also struggle with our labor force in long-term care, the number of people that can help us care for this older population. By the year 2035, we will have more people over the age of 65 than we have under the age of 18. This puts a lot of pressure on our system in terms of caring for this older adult population. It means things like we heard last night with artificial intelligence and data become more important to helping us take care of this population, in addition to making us more efficient. It also means that we have to act more as a team, and we have to be nurses, physicians, pharmacists working together to help tackle the challenges that we have with the older adult population. I like to talk about the US population in terms of birth rate and not age. So this is the birth rate curve for the United States starting in 1905 through 2002. People that are 80 years old, if they were born in 1960, by 2040, when they will be 80 years old, that will represent the very top of the birth rate in the United States history. That will be the peak of our progression into this older adult population. Just last year, 2023, if you were born in 1943, you're 80 years old is just sort of the first step on this journey to the top of this mountain of people as they age in this country. And in 2018, that was when the US had its lowest birth rate. The birth rate in 1938 was the lowest. So if you were born in 1938, you turned 80 in 2018. That really represented the beginning of when we started to see an increase in our very older adult population of over 80. This is important because it really changes how we focus on how do we take care of a population. We're not focused just on today. We're focused on what do we do in 5 years, in 10 years? How do we prepare to care for an older adult population that has a very large medication use and is growing so rapidly? So ASCP is the American Society of Consultant Pharmacists. It was founded in 1969. It started around the time that nursing care centers began to emerge in the United States. And the nurses that were at those nursing care centers had a problem. They had 100 individuals or residents living in their nursing facility. They were taking anywhere from 6 to 8 medications at one time. And in the United States, we had little amber vials that we dispense our medications in. So they had 800 of those in the nursing home. And the nurses were concerned about how do we manage this? How do we handle these 800 vials of medications? How do we do this efficiently and make sure our patients are getting their medication? So they consulted to the local community pharmacist and said, help me do this. And that was really the beginning of ASCP and this entire industry of long-term care pharmacy, where the pharmacist is central to making sure that the medications are managed, both from a logistical perspective, delivery, storage, packaging, and then also from a clinical perspective. How do I take care of an individual that's on 8 or 10 medications, and how do I get them to be clinically managed so that they're safe and that the medications are effective for the problems that they have. So those two fronts really evolved over the last 55 years in the US through ASCP at how do we get better at these things? How do we get more engaged to make sure that people are safe and effective with their medication use? Our long-term care environment is organized very similar to Poland, and I'm sure very similar to other countries. We have an independent living area model, people that live at home. They could be living in over 55-year-old communities together, in apartments, and even in neighborhoods. It's the way people prefer to live. We all prefer to live at home. And it represents the largest portion of our older adult population. It is the least expensive in terms of care, but is primarily self-pay and a little bit of insurance and a little bit of government insurance from Medicare, but it's limited government support. We also have assisted living centers. Those are a step up in terms of care. There's nursing involvement in those centers. It's a congregate living design, so it is more of a campus or an apartment complex. They have the ability to have cognitive support, ambulatory support, medication administration support, and it is ultimately very self-pay from the perspective of the patient. Government-assisted individuals really don't have an opportunity to be in assisted living. It's only for people that can afford to pay for that service. And then finally, we have skilled nursing homes, which is almost completely government supported. It is for individuals that do not have resources to pay. It is the highest level of services for our patients. It is 24/7, 24 hours a day, 7 days a week, nursing support. Nurses administer all the medications, and very much like we've seen in our trip in Poland, very similar to your skilled nursing centers. To give you an idea of how people fit into these different categories, an independent, these are individuals that live alone. They live with their caregiver or their spouse, and they live in those naturally occurring older adult communities. Assisted living is more communal living. It is very broad in its interpretation. Different states in the United States can look at assisted living differently. It could be 10 people living together in a house. It could be 120 people living in a locked dementia unit or facility in assisted living. So there's multiple versions of assisted living, but again, it's all self-pay. People have to pay for that service. And then finally, skilled nursing homes. We spend a lot of time in the United States with rehabilitation. So individuals that have clinical events that go to the hospital will come to the nursing home for 2 or 3 weeks. They will get services, and they will return to their home. We also have nursing homes and parts of nursing homes where individuals remain for the rest of their life with 24/7 nursing care. The medication management in the nursing home is sort of the backbone or the foundation for how pharmacists and pharmacies play a role in medication use and in long-term care. And a pharmacist is required to be in a nursing home every calendar month to review all the medications for each resident of that nursing home and communicate their evaluation of those medications to the physician on a monthly basis to try to improve care, to try to reduce unnecessary medications, to make sure that those medications are safe, there's not any drug interactions, and ultimately work as a team to improve the quality of life for the individuals in those skilled nursing centers. So as of February of this year, there were more than 15,500 licensed nursing homes in the United States, and there were 30,600 assisted living centers. 35% of the US healthcare dollar is spent caring for individuals over the age of 65, so it is a major part of our economy. Our Society of Retired Persons that represent people over the age of 65 estimate that the economic value of family care or support care from caregivers is about $600 billion a year. So we spend a lot of money as families, as sons and daughters, as moms and dads, supporting individuals over the age of 65 that may have needs. Medicare is our government assistance for people over the age of 65. It serves nearly all U.S. adults over 65 and accounts for $700 billion in annual spending, or 3% of the United States gross domestic product. By 2050, there will be an additional 40 million people relying on the Medicare system seeking senior living. So we are at a crossroads of how do we better care for individuals efficiently from an economic standpoint and from a need standpoint because of the number of individuals that are moving into that age group. ASCP represents 5,000 licensed pharmacists, 1,500 long-term care pharmacies. These are specialized pharmacies that only service nursing homes, only service assisted living. They have packaging benefits to people with complex drug regimens. So again, it comes back to those two fronts that we work on in America. The front of packaging medications, delivering medications, and then the other side, which is the clinical management of the individual patient. So what do our members do? What do pharmacists do in the United States? They handle this problem. Lots of medications, unorganized, chaotic. How do we make that simple? How do we make that easier so it's effective for patients? We package differently in the United States. We take bulk medications and we will individually package them specifically for each patient, again, to make it easier for them to manage their medications. We use things like blister cards, which is older technology, but one of the earliest innovations of packaging in the United States. And we now use what we call pouch packets. And those pouch packets are machines that package bulk medication into an individual strip of medication that is organized by the pastime of the medication. So somebody would get a strip of medications and all of their 8 a.m. meds would be in a pouch, followed by a noon pouch, followed by a 4 o'clock pouch, followed by an 8 p.m. pouch. And it would make it much easier for an individual, whether they live at home or even in our nursing facilities for our nurses, to pass and handle those medications and administer those medications. Now this is sort of a garden variety, a classic medication list for an individual in the United States. And if you look at this list, you can see the complexity. How does an older adult, particularly an older adult that lives at home or with their spouse, manage this? How do they take all these medications? How do they remember what time to take them? They're taking them 4 times during the day. They're taking multiple meds at the same time. They're dealing with medications that are small, easy to drop, easy to miss, easy to mistake. Our system in the United States has pharmacists deployed to help make this easier, to make sure that patients can manage a drug regimen that looks like this, and ultimately to try to make this drug regimen, again, simple, easier for them to deal with. So what do our members do? They work as a team. They work with the physician. They work with the nurses. They not only are handling the packaging of the medication, but they're handling the clinical aspects of that medication use. Pharmacists in the U.S. are responsible to individually label a prescription, deliver it to a nursing facility, make sure that in that nursing facility the medication is stored properly, that it's handled properly. They're even responsible to educate nurses on how to administer the medication. So if it's an IV medication or an inhaler or it's an injection, making sure that the nurses understand how to give those medications. And then again, they spend a lot of time looking at those medication regimens, looking at the patients, and finding out which medications are necessary, which ones are unnecessary, which ones have doses that are too high, too low, and then communicating to that physician recommendations for how to make it better for that individual, lowering doses, eliminating medications, making it simple but more effective for that individual patient. And this is what it looks like when we're making those interventions. You can see that there are multiple problems with that medication list, all identified through the use of a consultant pharmacist who has the information at their fingertips, as well as the ability to identify those problems, communicate those to the physician and the nursing team, and make those drug regimens more safe and effective for individuals. From a policy perspective in the US, a lot of what we're doing is similar to, I think, what all of us are doing, increasing the awareness about long-term care pharmacists, what they do to the public. We see pharmacists moving from nursing homes and assisted living out into the community. We know with 40 million more individuals coming of age of 65, becoming 80 years old, they'll be living in their home. They'll be living in the community where they don't have access to some of the traditional pharmacist resources that people in nursing homes have. So how do we get those services out to them? Increasing the public's awareness of those services is one way. We're trying to improve the medication access. We're trying to improve the innovation around ways to package, ways to measure whether someone is compliant or adherent with their medication, and ultimately making sure it's affordable, that they can pay for it. Improving the medication management for older adults is a priority in the US. In addition, our pharmacists spend a lot of time immunizing, providing education around immunization, and getting shots into arms for individuals as they age according to the recommendations of our CDC, or our Centers for Disease Control in the US. The other side of this is making sure it's funded. Pharmacists can't just do this on the side. They have to be funded to do this. I think people would be surprised that having a pharmacist review medications once a month in a nursing home is not as expensive as you might think. Most pharmacists in the US will have 6 or 7 nursing homes that they go to. These are pharmacists that don't touch product, they don't dispense. All they do is go into the nursing homes, look at the medication regimens, work with the patients and the nurses, and make recommendations to the physician. 6 or 7 nursing homes, 700 or 800 residents is a typical monthly workload for a consultant pharmacist. They use technology. We're trying to make sure our systems are more interoperable so that the physician system and the pharmacy system and the electronic medical record at the nursing facility all communicate so that we're all seeing the same data about that patient at the same time. So we're preparing for that silver tsunami and supporting long-term care, healthy aging in the US. And with that, I will open it up to any questions. Thank you.
Zapraszamy do zadawania pytań.
Feel free to ask questions. There are microphones waiting. I think we had an excellent opportunity to have an overview of a system that's been working very well in the US. And some of you probably see in your institutions, your facilities, and social care homes and nursing homes that currently in front of our eyes, such a system is being implemented in Poland. So I think that, the basic question we would have is, because since we have just started on the journey, I hope we will not stop halfway. The basic question is, do you have any advice, something we should pay special attention to facilitate this process, for this process to work in Poland?
Advice is, we recognize that the population is aging. We recognize that they use a lot of medications. We need to recognize that there is risk and that there are safety concerns with the use of a lot of medications in a particularly vulnerable, frail population. So making sure that we build systems that help identify that that we are documenting and looking at data about individuals and using that as a team, as a physician, a nurse, a pharmacist together to try to come up with the best ways to apply those medications to patients. It's about safety, it's about risk, and it's about making sure that that resident is getting the most out of the medications that they're taking.
Thank you very much. Thank you for amazing presentation and giving us opportunity to touch this system. Chad, niestety.
Unfortunately, Chad has to leave us, but I have good news for you. Should you have any questions later on, at the conference we have two more people from the ASCP, Dagmara Zając, and you can always go to her and ask her. Additionally, Dagmara speaks Polish very well, so there will be no language barrier if you would like to ask any questions. We also have with us another person, Jim Lewis, Senior Director of Policy and Advocacy, who also accompany Dagmara. So should you have any questions, feel free to ask them. Chad?
And have a nice trip.
Dziękuję.